Hi everyone and welcome to our module on the bones of the upper limb. In this module, we're talking about everything there is to know about the bones of the upper limb. We focus on each of the different bones at the different regions of the upper limb. The clavicle and the scapula found at the pectoral region, the humerus found at the arm, the radius and the ulna and the forearm, and then the bones of the hand. We have a total of 32 bones in the entire upper limb. These bones tend to span the length of the upper limb and they are all divided based on the regions of the upper limb. For example, the clavicle and the scapula are found in the pectoral region of the upper limb. The humerus is found in the arm. The radius and ulna are bones of the forearm, and then the carpal bones, the metacarpals, and the phalanges are all bones of the hand. Now, this is a picture showing for us the bones of the upper limb. Now, this does not include the clavicle and the scapula. So we can see the humerus being the first here, the most proximal bone, and it's the only bone found in the arm. We can see the radius and the ulna here. So this is going to be the ulnar bone here, and then this is the radius here. And then we can see the bones of the hand, which includes the carpals, the metacarpals, and then the phalanges, which are going to be forming the bones of the fingers. Starting off with the clavicle is the first bone of the upper limb we'll be talking about today. And this is very important to note because the clavicle tends to be the bone that directly connects the upper limb to the axial skeleton. So the axial skeleton contains or is composed of the thorax, the abdomen, all the way down to the pelvis and perineum. And it's the part of the body that is found in the middle. Whereas the upper limb and lower limb tends to be the appendicular skeleton. They are found at the extremities. The reason why we call them upper extremities and lower extremities. And the clavicle tends to be the bone that directly connects the upper limb to the trunk. Clavicle in terms of shape is described as S shape, and in terms of classification is classified as a long bone. This is very important to note for your in course. In terms of colloquial terms, we tend to refer to the clavicle as the collarbone, and in terms of position, the clavicle tends to be found subcutaneously. In fact, when you touch the region of the pectoral girdle where the clavicle is found, you could easily feel the clavicle, easily palpate it, which means that it's directly beneath the skin. The clavicle alongside the scapula tends to form the pectoral girdle. Pectoral girdle is more of a junction between the axial skeleton and the appendicular skeleton. In the case of the upper limb, we call it the pectoral girdle. In the case of the lower limb, we call it the pelvic girdle. Talking in detail about the clavicle in terms of its anatomy, clavicle as a bone is divided into two ends and a shaft. It's divided into three parts. So the two ends, one is pointing towards the axial skeleton, the other is pointing towards the rest of the appendicular skeleton. And those two ends are the sternal end and the acromial end. And then in between the two ends, we have a shaft that tends to connect them. I'll show a picture of how it looks like. Now, this is a picture of the clavicle. As I said before, the clavicle has three major parts to it. It has a sternal end, an acromial end, and a shaft that connects them. So, to quickly illustrate, the sternal end is this aspect of the clavicle. It connects the clavicle to the axial skeleton, so it's connecting it to the trunk. Whereas the acromial end is this portion of the clavicle. It's the part of the clavicle that connects it to the rest of the appendicular skeleton, so it's connecting it to the scapula. And in between the acromial end and the sternal end, we have a longer portion of the clavicle called the shaft. So this is the shaft or the body. So as I said before, the sternal end tends to be the end that connects the clavicle to the axial skeleton. In terms of description, we say the sternal end is found medially, so it's pointing towards the middle of the body. One very important thing to note about the sternal end, especially when you are going to the labs and you are asked to identify the clavicle and the part of the clavicle, is the fact that the sternal end tends to be quadrangular in shape. It tends to have a bulge shape. And this is contrast to what we have in the acromial end, which is flat in shape. So please do note the shape of the sternal end. They can ask you in your questions, and you could also use it as the point of reference when handling the clavicle physically. Sternal end of the clavicle tends to articulate with the sternum of the axial skeleton, and the articulation between the sternal end of the clavicle and the sternum in the axial skeleton is what gives rise to a joint called the sternoclavicular joint. We'll talk about this joint when we get to the module on joint of the upper limb. So like I said before, the acromial end of the clavicle is the portion of it that connects it to the rest of the appendicular skeleton. In terms of its position, the acromial end is referred to as flat in shape, and it's oriented laterally, so it's pointing towards the lateral part of the body away from the midline. And the acromial end tends to articulate particularly to the scapula. That's the part of the appendicular skeleton that is connecting to. And this articulation gives rise to another joint called the acromioclavicular joint. We'll talk about this joint when we get to the section on the joint of the upper limb. And finally, the shaft of the clavicle is further divided into two parts. So divide the shaft of the clavicle into a lateral one third and a medial two third. And this is very important to note. So if I take the shaft of the clavicle here, so let's divide this clavicle one more time. So this is the sternal end, this is the acromial end, and in between is the shaft of the body. This shaft that you can see here can further be divided into two portions. So we can divide the shaft into a medial two third. So this is the medial two third. Medial two third is the closest part to the sternal end, and then we can divide the rest of the shaft of the clavicle into a lateral one third. The lateral one third is the part closest to the acromial end. When you get to the labs, you would have to identify this area, this portion, the lateral one third and the medial two third. And how we tend to identify them is that once we are visualizing the sternal end, and we know that the sternal end is going to be connected directly to the medial two third. The medial two third must always contain a convex portion on its anterior border. So let me show you what I mean by that. So look at this. This is the sternal end here, right? And this automatically means that the part of the shaft connected to the sternal end would be the medial two third. What you notice about the medial two third is that anteriorly, so this is the anterior portion here, anteriorly, the medial two third tends to be convex, tends to shoot forward or bulge forward. It's convex, so it has like a bulge forward. So we say that the medial two third is convex anteriorly. This is contrast to what we have in the lateral one third. The lateral one third, as you can see, is the part of the shaft connected to the acromial end. So this is the lateral one third here. And what you notice that the lateral one third of the clavicle tends to be concave anteriorly. You can see it being concave. So look at this. You can see how it bulges inward. So the bulging inward is the concavity that we see in the lateral one third, and then the bulging outwards is the convexity that we see in the medial two third. This is the way in which we identify it physically when we get to the lab. Last thing to talk about under the clavicle would be the landmarks of the clavicle. So what are landmarks? Landmarks are practically depressions and elevations found on bone surfaces. It's very important to note that bones do not contain smooth surfaces. Right, most bones tend to have either a bulge or a depression, and these bulge or depressions are called landmarks. For the clavicle has a total of 5 major landmarks that you must know. And why this is important to note is that when you guys are being tested on in your practical session, they will love to ask questions in relation to the landmark. So they could paint a landmark to you for you, either paint an elevation or a depression on the bone and ask you to identify the landmark or identify what is attached to that landmark. So one thing to note is that aside knowing the landmarks themselves, you also need to note what is attached to them, which is what I'll refer to. I'll show you pictures of the landmarks in the next couple of slides. The first landmark to know regarding the clavicle is called the subclavian groove. So this is a groove that is found in the middle of the clavicle, in the middle or the shaft of the clavicle on the inferior surface. And what is attached to the subclavian groove is a muscle called the subclavius muscle. So remember, the subclavius muscle is the muscle found on the subclavian groove. The second landmark is the impression of the costoclavicular ligament. So it's a depression, and it's a depression that is found close to the sternal end. And what is related to this impression of the costoclavicular ligament, as the name implies, is the costoclavicular ligament itself. So it's an impression, is a depression for a ligament, and that impression or depression is found close to the sternal end. So remember that the costoclavicular ligament, CCL, is the structure related to the impression of the costoclavicular ligament. The third landmark of the clavicle is called the tuberosity of the coracoclavicular ligament. This one is found laterally. This one is found very close to the acromial end or the lateral end of the clavicle. I'll show you a picture of how it looks like. And what is related to the tuberosity of the coracoclavicular ligament, as the name implies, is the coracoclavicular ligament itself. So please remember that there's the costoclavicular ligament and there's the coracoclavicular ligament. The costoclavicular ligament is related to the impression for the costoclavicular ligament, whereas the coracoclavicular ligament is related to the tuberosity of the coracoclavicular ligament. So please do note that. All right, one more thing to remember would be the conoid and the um, trapezoid line, conoid tubercle and trapezoid line. These are also impressions that are found very close to the acromial end. The conoid tubercle, for example, is related to the conoid ligament, and then the trapezoid line is related to the trapezoid ligament. In fact, these two ligaments, the conoid ligament and trapezoid ligament, are actually parts of the coracoclavicular ligament. So we can say that the conoid tubercle and the trapezoid line are also portions of the tuberosity of the coracoclavicular ligament. And this is a picture of how the landmarks tend to look like. The landmarks that are shown in these pictures are just a few. You can see the impression of the costoclavicular ligament here in blue. You can see it's very close to the sternal end, so it's very close to the medial part of the clavicle. And we can see the tuberosity of the coracoclavicular ligament. And that tuberosity is divided into two parts. It's divided into a conoid tubercle here, which is the portion where the conoid ligament is attached to, and it's also divided into a trapezoid line, which is the portion where the trapezoid ligament is attached to. The combination of the trapezoid ligament and the conoid ligament gives us the coracoclavicular ligament, and that's the ligament that attaches to this entire portion. This entire portion here is called the tuberosity of the coracoclavicular ligament. The only landmark that is not visible in this image here is the landmark for the subclavian groove, and that landmark is found somewhere around this area. It's the landmark found in the middle of the shaft, and it's a landmark that tends to house the subclavius muscle. Right, so this picture shows us some of the landmarks alongside other areas where muscles tend to attach to. Right, so this is not really high yield for your in courses, but it's important to just note that aside the subclavius muscle, we also have some other muscles that tend to attach to the clavicle. Some of the muscles attaching to the clavicle, for example, at the acromial end, at the lateral part of the clavicle, we have two major muscles attaching to the clavicle. We have the deltoid muscle in front and the trapezius muscle at the back. All right, in the middle of the shaft of the clavicle, we have the subclavius muscle. And you can see the subclavius muscle here in blue. It's in the middle of the clavicle. It's found directly in the subclavian groove. And then when we go to the sternal end of the clavicle, we have some other muscles in the sternal end. So, for example, the anterior part of the sternal end of the clavicle, we have the pectoralis major muscle here. So this is one muscle here. All right, very close to the sternal end, we have muscles at the top of the clavicle called the sternocleidomastoid muscle. So this is the sternocleidomastoid muscle here. And then we have the last set of muscle here called the sternocleidomastoid muscle. This is the sternocleidomastoid muscle found around this portion. These are the muscles that are all related to the clavicle. Like I said, they're not really high yield. They will hardly test you on these muscles. The only muscle I can see them testing on will be the subclavius muscle, and that is because of its relation to the subclavian groove, which is the landmark. The scapula is the second bone in the pectoral girdle, so it's the second bone that tends to connect the appendicular skeleton of the upper limb to the axial skeleton. It is not in direct connection. The scapula tends to connect to the appendicular skeleton, while the clavicle tends to connect to the axial skeleton. But both of them together would form the pectoral girdle and the junction between the appendicular and the axial skeleton. The scapula, in terms of shape, is referred to as a triangular shaped bone. Remember that the clavicle is S in shape. And in terms of classification, the scapula tends to be classified as a flat bone. This is contrast to the clavicle, which is classified as a long bone. The colloquial term for the scapula is the shoulder blade. So remember that the colloquial term of the clavicle is the collarbone. For the scapula, it's called the shoulder blade. And we'll talk about everything there is to note about the scapula in the next couple of slides. All right, one very easy way to remember the different parts of the scapula is what we call the rule of three. So most parts of the scapula tend to follow three rule. All right, the borders of the scapula are 3 in number, the angles of the scapula are 3 in number, the processes of the scapula are 3 in number, and then the fossas are 3 in number. So we say that the scapula has 3 borders, 3 angles, 3 processes, 3 fossas. The processes and the fossas are part of the landmarks. We'll talk about them when we talk about the landmarks. Right? But for the angles and the borders, the 3 angles of the scapula includes the superior angle, the inferior angle, and the lateral angle. The lateral angle is also called the glenoid cavity. The borders of the scapula, whereas, includes the medial border. The medial border is also called the vertebral border, so please note that it's also called the vertebral border. The lateral border of the scapula is also called the axillary border. And then we have the superior border of the scapula. So these are the borders of the scapula. I'll show you a picture of how each of these borders and angles tend to look like, and we'll talk about the processes later on. Just to make mention of the processes, three processes of the scapula include the acromion process, the spinous process, and the coracoid process. And then the three fossas of the scapula include the supraspinatus fossa, the infraspinous fossa, and the subscapular fossa. Now, this is a picture of the scapula, and you could easily deduce the different aspect of the rule of threes for the scapula. Starting with the borders. Remember, the scapula has three borders. We have the superior border found here. All right, then we have the medial border. Medial border is also called the vertebral border. And then we have finally the lateral border. Lateral border is also called the axillary border. So these are the borders of the scapula. Then remember, the scapula has three angles. Three angles include the superior angle here, the inferior angle here, and it's very important to note that the superior angle is related to the second thoracic vertebrae T2, whereas the inferior angle is related to the seventh thoracic vertebrae T7. That's very key to know. So we tend to say that the scapula extends from T2 to T7. Then finally, we have the lateral border. Lateral border is also called the glenoid cavity, and this is the border you can see here. This is the lateral border here. The other aspect of the rule of threes are the processes and the fossas of the scapula. So starting with the processes, the scapula has three major processes, the coracoid process being the first one. This process is found anteriorly, as you can see, and then the other two processes are found posteriorly. This includes the acromion process here and the spinous process. This is the spinous process, is the longest of the three processes. Then we have three fossas of the scapula. Three fossas of the scapula includes the subscapular fossa. So it's a big depression found in the anterior part of the scapula, as you can see. So this entire area is the subscapular fossa. Then we have the supraspinous fossa found at the top here, at the back of the scapula, right? And then the infraspinous fossa found below here. This is at the bottom of the posterior surface of the scapula. The supraspinous and infraspinous fossa are splitted or divided by the spine, by the scapular spine or the spinous process. So the spinous process divides the back of the scapula into supraspinous fossa and infraspinous fossa. One more thing to mention, the scapula tends to have two surfaces. There's a surface that is found anteriorly, as the anterior view that you are seeing here. So this surface is called the costal surface or anterior surface. And there's a surface found posteriorly. This surface is also called the vertebral surface or the posterior surface or the posterior view. Now, I already mentioned this in the previous slide. The scapula tends to contain two surfaces, anterior surface or the costal surface, as you can see, and then the posterior surface or the vertebral surface, as you can see. So among the three processes and the three fossas of the scapula that we mentioned, the anterior surface tends to contain one of each. So in the anterior surface of the scapula, we have the subscapular fossa being the fossa dominant there, and in the anterior surface of the scapula, we have the coracoid process being the process dominant there. For the posterior surface of the scapula, remember it's also called the vertebral or the scapular surface. This surface tends to contain two of the processes and the fossas that we mentioned initially. So in the posterior surface, we have two fossas, supraspinous fossa and infraspinous fossa. And then we have two processes found in the posterior surface. We have the acromion process and the spinous process. Let's talk about the landmarks of the scapula. So we've talked about some of the structures that forms the landmarks of the scapula when referring to the fossas and the processes. But what we'll do in this particular slide is to talk about them in relation to the structures that are attached to them. The first landmark of the scapula is the subscapular fossa. This is the fossa that is found on the anterior surface of the scapula, and is related to a muscle called the subscapularis muscle. The second process or landmark of the scapula is the coracoid process. This is a process or elevation found on the anterior surface of the scapula as well. It is related to a number of structures, including muscles and ligaments. So some of the muscles that are related to the coracoid process includes the short arm of the biceps brachii muscle, the pectoralis minor muscle, and the coracobrachialis muscle. So these are the muscles that are found on the coracoid process. And we have some ligaments that are related to it. Particular ligament that is worthy of note is the coracoclavicular ligament alongside the coracoacromial ligament. Those are the two ligaments that we find attached to the coracoid process. The third landmark of the scapula is the glenoid cavity. And the glenoid cavity is also called the lateral angle. The glenoid cavity is related to a joint in the upper limb alongside some muscles that are attached to them. So the joint that tends to be related to glenoid cavity is the glenocavicular joint, the glenohumeral joint rather. So this is also called the shoulder joint. And then the muscles that are related to the glenoid cavity are the long hand of the biceps brachii muscle and the long hand of the triceps brachii muscle. So please do remember LB and LT. Then we have the acromion process. The acromion process is one of the processes I mentioned. It's found at the posterior surface of the scapula. And the acromion process is related to a joint. The joint that is related to is the acromioclavicular joint. And that's the joint that tends to connect the clavicle to the scapula. Then we have the spine of the scapula. The spine of the scapula is found as well in the posterior surface of the scapula. It is not necessarily related to a number of structures, but what it does do is that it divides the entire posterior surface of the scapula into two fossa. It divides it into a supraspinous fossa and an infraspinous fossa that we'll be talking about next. The supraspinous fossa is the second fossa found in the posterior surface of the scapula. This fossa is related to a muscle, and the name of that muscle is the supraspinatus muscle. So supraspinatus muscle, SSM. The infraspinous fossa is the third fossa found in the posterior surface of the scapula, and this fossa is also related to a muscle. The name of the muscle is the infraspinatus muscle. Then finally, we have one more structure, one more landmark, which is a notch, a depression, and that depression is found at the superior border of the scapula. The depression here is called the suprascapular notch, and the suprascapular notch tends to form a passageway for structures, particularly structures like the suprascapular nerve and the suprascapular artery. These are the structures that tend to pass through the suprascapular nerve, so they are related to it. So you could see them put a straw or a probe through the suprascapular notch in your questions, in your practical questions, and ask you what is related. So please do remember that the suprascapular arteries, the suprascapular veins, and the suprascapular nerves are the structures related to the suprascapular notch. This is a picture of some of the landmarks that we've talked about already. This is showing us the anterior surface of the scapula. You could see that some of the structures that we talked about are visible here. That is subscapular fossa here, which is the site of attachment for the subscapularis muscle. You can see the glenoid fossa here, which is the site of attachment for the long hand of the triceps and long hand of the biceps, and is also the site for the glenohumeral joint or the shoulder joint. You can see the coracoid process here in red, and you can see that remember that a lot of structures are related to the coracoid process, muscles and ligaments alike. And then finally, we have the acromion process at the back in green, which is the site of the acromioclavicular joint. For the posterior surface of the scapula, we have more landmarks present there. The acromion is more visible in the posterior surface. You can see the acromion, which is the site of the site for the acromioclavicular joint. You can see the supraspinatus fossa in pink or purple, and that supraspinatus fossa, like I said, is the site of attachment for the supraspinous muscle. And then finally, the infraspinatus fossa or infraspinous fossa being the site of attachment for the infraspinous muscle. There's the suprascapular notch found directly at the superior border. You can see the notch visible here. It's just between the superior border and the coracoid process. So this small tiny notch here is the suprascapular notch, and we have some neurovascular structures passing through that notch. So the suprascapular nerve, suprascapular artery, and the suprascapular veins are the structures that tend to pass through the suprascapular notch. Moving on to the humerus. The humerus is the only bone found in the arm. It's the longest bone of the upper extremity, and it's the bone that tends to connect the pectoral girdle to the forearm. Remember that the pectoral girdle contains the scapula and the clavicle. The humerus is directly articulated to the scapula, and the articulation between the scapula and the humerus gives rise to what we call the shoulder joint. This humerus also tends to connect to the forearm, and is connected to the bones of the forearm, the radius and the ulnar bone. We'll talk about that next. And the site of connection gives rise to the elbow joint. Let's talk about the part of the humerus in terms of anatomy. The humerus, being a long bone, is divided into three major parts. So there's a part that is found superiorly, which is called the proximal end. So this is the proximal end here. It's a part that is going to be articulating with the scapula or the pectoral girdle. There's the distal end. The distal end is the part that is articulating with the radius and ulna at the elbow, and this is the part that is found inferiorly. And in between the distal and proximal end, we have the shaft, which is the longest part of the humerus. Let's talk about the landmarks of the humerus. So each of those different parts of the humerus have different landmarks. Remember, landmarks are bumps or depressions found on the bones, and they tend to serve as site of attachment for muscles, ligaments, and tendons. Starting with the proximal end of the humerus, we have a total of 6 different landmarks on the proximal end of the humerus. The largest landmark on the proximal end of the humerus is called the head of the humerus. The head of the humerus tends to be related to the humeral joint. Is usually the part of the humerus that would articulate with the scapula. So it's involved in the articulation and the formation of the shoulder joint of the glenohumeral joint. Then we have the anatomical neck. The anatomical neck of the humerus is related to what we call a fibrous joint capsule. We'll talk about that when we get to the pictures part. And then we have the greater tuberosity or greater tubercle. The greater tubercle is related to a number of muscles. We'll mention that when we get to that section. We have the lesser tuberosity or lesser tubercle, also related to a number of muscle structures. And then we have the bicipital groove or intertubercular sulcus. Right, the structure that is found on this particular groove or this particular sulcus is a combination of two things. First of all, is a tendon and then a muscle. The muscle there is the latissimus dorsi muscle, and then the tendon there is the long arm of the long arm of the biceps brachii muscle. So the long arm of the biceps brachii is represented as LB, and then latissimus dorsi is represented as LD. The bicipital groove or intertubercular sulcus is a small groove in between the greater tuberosity and lesser tuberosity, and this is very important for you to note. And then finally, we have the surgical neck of the humerus. And one very important structure is related to the surgical neck of the humerus, and that structure is the axillary nerve. Axillary nerve is found wrapping around the surgical neck. Aside the axillary nerve, we have some other structures found at the surgical neck. These structures include the anterior and posterior circumflex humeral arteries. So these are arteries that wrap around the surgical neck. So anterior and posterior circumflex humeral arteries are the other structures found at the surgical neck. Very important to note, the surgical neck tends to be the weakest point on the humerus, and it tends to be the point where fractures can occur. When we get to the clinical application section, I will revisit this particular point, and we'll talk about the different side effects that could occur when there's a fracture of the humerus at the surgical neck. And this is a picture of the landmarks we just talked about. So starting with the most obvious landmark, which is the head of the humerus, you can see it in red. So this is the head of the humerus that tends to articulate with the glenoid cavity to form the glenohumeral joint or shoulder joint. Then we have the greater tubercle. The greater tubercle is represented in blue here. It's one of the tubercles or tuberosities that tend to serve as attachment points for muscles. The muscles that we tend to see attaching to the greater tuberosity or tubercle are the muscles of the rotator cuff. So we have supraspinatus muscle, infraspinatus muscle, some part of the teres minor muscle attaching to the greater tuberosity. For the lesser tuberosity is represented with yellow image here. So this is the lesser tuberosity. Sorry, the lesser tuberosity is represented in green here. So this is the lesser tuberosity here. Right, lesser tuberosity is also related to the rotator cuff muscles, particularly to the subscapularis muscle, which is one of the rotator cuff muscles. We'll talk about the rotator cuff muscles when we get to the module on joints of the upper limb. The last two landmarks shown here are colored, one in yellow and the other one not really colored. The first one in yellow is the anatomical neck. This is the one structure here in yellow. The anatomical neck tends to serve as point of attachment for the joint capsule. And then we have the surgical neck. Surgical neck should be found somewhere below at this point here. It's not really shown in this image, but I'm outlining it with this red mark. The surgical neck is related, like I said, to the axillary nerve, the anterior and the posterior circumflex humeral arteries. Let's go on to the shaft of the humerus. The shaft of the humerus is the longest part of the humerus. It is related to a number of muscles, but the two major landmarks that we find in the shaft of the humerus are the deltoid tuberosity. Deltoid tuberosity, as the name implies, is related to the deltoid muscle, and then the radial groove. The radial groove is a very small line depression found on the shaft, at the middle of the shaft of the humerus. What is related to the radial groove are two major structures. The radial nerve is found at the radial groove, and then a particular branch of an artery called the profunda brachial artery or the deep brachial artery. So the profunda brachial artery or deep brachial artery is a branch of the brachial artery itself. So it is an artery found at the radial groove. This is a picture showing us the entire humerus, but we're going to pay attention to the shaft. On the shaft, you notice there are two major landmarks there. The deltoid tuberosity found at the lateral part of the shaft. So you can see the deltoid tuberosity found here. And then the radial groove or groove of the radial nerve, which is also called the spiral groove. So in case you see spiral groove is also called radial groove. There's another name for it. And that groove is found at the back of the humerus. It's found at the posterior surface of the shaft. And that groove is related to the radial nerve and the profunda brachial artery. Deltoid tuberosity, like I said, is related to the deltoid muscle. The last part of the humerus is the distal end of the humerus, and this contains even more landmarks. Starting with the medial epicondyle. The medial epicondyle is an elevation or a bulge found at the distal end of the humerus that points medially. And this medial epicondyle is related to a number of structures, including the ulnar nerve. The ulnar nerve is found at the back of the medial epicondyle, the flexors of the forearm or forearm flexors, and then the pudendal muscle. These are muscles that tend to originate at the medial epicondyle. The second landmark of the distal end of the humerus is the trochlea. The trochlea is a bulge at the distal end of the humerus that tends to be involved in the formation of the elbow joint. So it's one of the structures that will articulate with the bones of the forearm. The trochlea is particularly involved in articulating with the ulna of the forearm. So it articulates with the ulna to form the elbow joint. Then we have the coronoid fossa. The coronoid fossa is a depression that is found directly above the trochlea. And this particular fossa tends to be a space where a part of the ulna would fit into. We'll talk about that part very soon. The name of that part is called the coronoid tubercle. So that part would fit into the coronoid fossa during a flexion or extension of the forearm at the elbow joint. Then we have the capitulum. Capitulum is also a bulge found at the distal part of the humerus. It is involved in the formation of the elbow joint, but unlike the trochlea, the capitulum tends to be involved in articulating with the radius of the forearm. So trochlea articulates with the ulna, capitulum articulates with the radius of the forearm. Then we have the radial fossa. Just as we have a coronoid fossa above the trochlea, we have a radial fossa above the capitulum. The radial fossa is also involved in the it comes in contact with the structure found on the radius, the landmark on the radius. The landmark in this case is the radial tuberosity. So the radial tuberosity tends to fit into the radial fossa of the humerus. The last fossa found within the distal end is the olecranon fossa. This fossa is found posteriorly at the back of the humerus, right? And this fossa tends to also fit in with a structure found in one of the bones of the forearm. That bone is the ulnar bone. The ulnar bone contains a process called olecranon process, and that olecranon process sits directly still within the olecranon fossa of the humerus. And these are the structures related to them. So if they ask you what's the structure related to the olecranon fossa, that's the olecranon process. If they ask you what's the structure related to the radial fossa, that's the radial tuberosity. If they ask about what is related to the coronoid fossa, that's the coronoid tubercle or coronoid process. So these are the structures related to each of them. The last aspect of the distal end of the humerus is the lateral epicondyle. This doesn't necessarily have structures directly related to it. The structures I can think about that's related to the lateral epicondyle should be some of the muscles of the forearm. Usually the extensor muscles of the forearm extensors are related to it, alongside a muscle called supinator muscle. Right, but we don't really have any nerve that is directly in contact with the lateral epicondyle as we do for the medial epicondyle. This is a picture showing us the different landmarks of the distal end of the humerus. From medial to lateral, we have the medial epicondyle. Remember that the ulnar nerve is found at the back of the medial epicondyle, so the ulnar nerve running somewhere around here. We have the lateral epicondyle at the lateral end of the distal part of the humerus, and in between them we have structures. Anteriorly, we have the trochlea. Trochlea is shown here in green. This is the structure that articulates with the ulna to form the elbow joint. We have the capitulum in blue. is the structure that articulates with the radius to form the elbow joint. And above both of them, we have some fossa. Above the trochlea, we have the coronoid fossa, which is a fossa of the person that fits directly with the coronoid process of the ulnar bone. And then we have the radial fossa at the top of the capitulum. This is a fossa of the person that fits directly with the radial tuberosity of the radius. At the back of the humerus, the distal end contains a larger fossa called the olecranon fossa. This is the olecranon fossa here. It fits very well with the olecranon process of the ulna. Each of those other processes that I mentioned, olecranon process, coronoid process of tubercle, and the radial tuberosity, we'll talk about them when we get to the section of the radius and the ulna next. Moving on to the bones of the forearm. The first bone of the forearm we'll talk about will be the radius. The radius is the most lateral bone in the forearm. The ulna, on the other hand, is the most medial of the two bones. The radius tends to articulate above with the humerus, and that articulation gives rise to the elbow joint. Remember that the connection between the radius and the humerus is directly by the capitulum of the humerus. Capitulum of the humerus articulates with the radius to form the elbow joint. The radius articulates with the carpal bones of the hand to give rise to the wrist joint. We'll talk about that when we get to the motor joint of the upper limb. And then finally, the radius also articulates with the ulnar bone within the forearm, and that articulation is found medially. The name of the joint that they give rise to is called the radioulnar joint. So we can say that the radius gives rise to three major types of joints. All right, the elbow joint proximally, the wrist joint distally, and then the radioulnar joint medially. Let's talk about the anatomy of the radius. The radius is divided also into three parts. It's a long bone, and it will have a proximal end that articulates with the humerus, a distal end that articulates with the carpal bones, and the shaft that tends to divide them from one another. Let's talk about the landmarks of the radius, starting with the proximal end of the radius. The proximal end of the radius has three major landmarks for you to remember. These include the head of the radius, the neck of the radius, and the radial tuberosity. The head of the radius is involved in the formation of the elbow joint. The head of the radius tends to articulate with the capitulum of the humerus to form the elbow joint. The neck of the radius is another landmark, and this particular structure is related to a ligament. The name of the ligament is called the annulus ligament. The annulus ligament is a ligament that wraps around the neck of the radius. And if you ever find a question on that in your practicals, which they are drawing a line around the neck of the radius and they ask you what's related, please do remember the annulus ligament of the radius. And then finally, we have the radial tuberosity, which is a bump found on the anterior surface of the radius. This is related to the tendon of the biceps brachii muscle. So biceps brachii tendon is related to radial tuberosity. And this is a picture of the three major landmarks of our proximal end of the radius. Starting with the head of radius, you can see it is circumferential in shape, and it tends to articulate with capitulum, as I said initially. It's a structure shown in yellow. And you can see the next structure below that is the neck of the radius, which is also circumferential in shape. What tends to be related to it is what we call the annular ligament of the radius. This ligament tends to wrap around it, hence the name annular. And then finally, we have the radial tuberosity. The radial tuberosity is represented in this particular shade, and what is attached to the radial tuberosity is the biceps brachii tendon. The shaft of the radius tends to connect the proximal and the distal end of the radius. The shaft of the radius is the longest part of the radius. It is cylindrical in shape. Please do remember the shape because this is distinct from what we see in terms of the shaft of the ulna. The shaft of the radius tends to expand in diameter as we go from proximal to distal. So from the proximal end to the distal end, the size or diameter of the shaft of the radius increases. And we say it contains two surfaces and two borders. This is not really high yield, but the surfaces of the shaft of the radius includes the anterior, posterior, and lateral surfaces. The lateral surface of the radius tends to be involved in the formation of the radioulnar joint. We'll talk about that joint when we get to the joint of the upper limb. And then the borders of the radius include the anterior border, the posterior border, and the interosseous border. And this is a picture of the radius and ulna shown here. We'll focus our attention on the radius alone. As you can see, the shaft of the radius does not really have any landmark, but what we do note about the shaft is that it is cylindrical in shape and it tends to increase in diameter. You can see that the diameter at the proximal end is different from the diameter at the distal end. There's an expansion of the diameter as we go distally, so we go downwards. And remember that the radius also has three surfaces and three borders. That is not really high for you to note. The last part of the radius, the distal and the radius, has two major landmarks. These are the radial slider process and the dorsal tubercle of Leicester. The one that is most important to remember is the radial slider process because of the structure related to it. The radial slider process is related to the radial artery. So if you are to ever palpate the radial artery and find out the particular location where it is found, first thing to do is locate the radial slider process, and just medial to the radial slider process, you should be able to palpate the radial artery directly beside it. The dorsal tubercle of Lister is a very tiny tubercle on the dorsal part or posterior part of the radius. It is not easily palpable, but is a tubercle that we would see if we're looking at the radius physically. So this is the distal part of the radius. As you can see, distal part of the radius is involved in forming the wrist joints together with the carpal bones. We'll talk about the carpal bones next. The radius also tend to have a larger part in terms of its distal portion compared to its proximal portion. You can see distal part being very bulgy compared to the proximal head of the radius. And this picture shows for us the landmarks that we mentioned. You see that the two major landmarks are visible here. You could see the radial styler process and then the dorsal tubercle of Lister. This is the dorsal tubercle of Lister. There's also a very small landmark called the sigmoid notch. Sigmoid notch is found here. It's not so important to note, but it's just one landmark shown in this image. And this is the radial styler process pointing here. So this is radial styler process. Just to quickly show those structures one more time. So this is the radial styler process pointing here. So this is the radial styler process here. And then this is the dorsal tubercle of Lister, although it's not really shown very visibly here. It should be somewhere around this point in the dorsal part of the radius. The ulnar bone is the second bone of the forearm. It's the most medial of the two bones. Remember that the radius tends to be found laterally. The ulnar, on the other hand, is found. And in terms of the differences between them, the ulnar bone tends to be longer compared to the radius. It articulates proximally with the humerus to form the elbow joint. Remember that the ulnar articulates particularly with the trochlea of the humerus to form the elbow joint. And then it articulates laterally with the radius to form the radioulnar joint. Please do note that the ulnar does not take part in the articulation of the wrist joint. Wrist joint is formed by a union of the radius, the carpal bones, and the articular disc. The ulnar does not take part in this particular formation. In terms of the anatomy of the ulnar is divided into three major parts. It's a long bone, so it's going to contain a proximal end, a distal end, and a shaft connecting them. Talking about the landmarks in the proximal end of the ulna, we start with the olecranon. The olecranon process is the largest landmark in the ulna, and this particular landmark is related to a number of structures. First of all, muscles. There are two major muscles found or attached to the olecranon process. These are the trochlear muscle, the anconeus muscle rather, and then the triceps brachii muscle. So the triceps brachii and the anconeus muscle are the two muscles attached to the olecranon. Aside that, remember that the olecranon process tends to also fit into the olecranon fossa found at the back of the humerus, and that's just very key to note. The next landmark of the ulna is the coronoid process. Coronoid process of the ulna tends to be directly in contact with the coronoid fossa of the humerus, as I showed you guys before, and that's what is related to it. Then we have the trochlear notch. Trochlear notch is a very big depression found on the proximal end of the ulna superiorly. The trochlear notch tends to be the site of articulation of the elbow joint. Remember that the ulna would articulate with the humerus, with the trochlea of the humerus to form the elbow joint. So the trochlea of the humerus articulates with the trochlear notch of the ulna to form the elbow joint. So please do note, trochlear notch is involved in the formation of the elbow joint. Then we have the radial notch. The radial notch is a very tiny notch at the medial side, at the lateral side of the ulna rather. And this notch tends to be the site of articulation between the radius and the ulna, forming a joint we call the proximal radioulnar joint. So proximal radioulnar joint is one of the types of radioulnar joints found in the upper limb, and that joint is by the union of the head of the radius and the radial notch of the ulna. Then we have the ulnar tuberosity. Ulnar tuberosity is the last landmark found in the proximal end of the ulna. This is a bump at the anterior surface of the ulna that is serving as the site of attachment for the brachialis muscle. So brachialis muscle tend to attach to the ulnar tuberosity. This is a picture of all the landmarks that I talked about in the proximal end of the ulna, starting with the olecranon because it's the largest and is the most posterior of the landmarks. And then we have the coronoid process. Coronoid process is a very big depression found on the superior anterior surface of the ulna, and this is usually the site of formation of the elbow joint when the trochlea articulates with the trochlear notch of the ulna. And then we have some other fewer or smaller landmarks. We have the radial notch at the side in blue. It articulates with the radius to form the radioulnar joint. And then we have the coronoid process in red. Coronoid process also contains a bit of the ulnar tuberosity somewhere around there. So coronoid process is involved in forming the contact with the coronoid fossa of the humerus. And because it contains the ulnar tuberosity, the ulnar tuberosity also is involved in the site of attachment for the brachialis muscle. Moving on to the shaft of the ulna tends to have a shaft that is regarded as either being triangular in shape or cylindrical in shape. Remember that the shape of the shaft of the radius is cylindrical. For the ulna, it tends to be triangular in shape. The diameter of the ulna also tends to differ in terms of the shaft compared to the radius. Remember that the radius diameter tends to increase as it runs distally. For the ulna, this is in an opposite manner of fashion. The shaft of the ulna tends to reduce in diameter as we go distally, so it tends to taper down as we go distally. And then the ulna also contains three major surfaces: anterior surface, posterior surface, and medial surface, as well as three borders that tend to form the surface. We have an anterior border, a posterior border, and interosseous border. But this particular aspect of the shaft is not really high yield. Let's talk about the shaft in terms of the image shown below. So remember that the shaft of the ulna tends to be triangular in shape. You can see the triangular shape depicted in the image here. And the reason why it's inverted triangle in that format is because the diameter of the shaft tends to taper down, tends to decrease as we go distally. So you can see the diameter of the proximal part of the shaft is large compared to the distal part of the shaft, which is very small. And this also kind of shows for us those surfaces and borders we talked about. The three surfaces and three borders of the ulna are depicted in this particular image, although they are not really high yield. The last part of the ulna is the distal end, and this particular aspect of the ulna contains two major landmarks. The first is the ulnar head of the ulna. The ulnar head of the ulna is involved in the formation of the distal radioulnar joint. So we have two major radioulnar joints, a distal and a proximal radioulnar joint. The distal radioulnar joint is formed when the ulnar head unites with the ulnar or sigmoid notch of the radius, whereas the proximal radioulnar joint is formed when the radial notch of the ulna articulates with the head of the radius. The second landmark in the distal end of the ulna is the styloid process of the ulna, and this is one particular structure that is very prominent compared to the styloid process of the radius. Although the styloid process of the ulna does not necessarily is not necessarily related to the ulnar artery or nerve, as compared to the radial styloid process, which is related to the radial artery. This is a picture of the distal part of the ulna. As you can see, it is not involved in the formation of the wrist joint. The wrist joint is formed by the radius in yellow, the carpal bones in green, and then articular disc. So the distal end of the ulna does not form the wrist joint. What it does form is a joint at the distal portion here called the distal radioulnar joint. You can see the joint between the ulnar head and the ulnar notch of the radius, somewhere around there, what we call sigmoid notch. So some of those processes that we talked about are visible here. As you can see, both the radius and the ulnar are shown in this picture. But what I want you guys to pay attention to is the styloid process of the ulnar shown here. You can see that the styloid process of the ulnar is more prominent compared to the styloid process of the radius. And in fact, when you touch that lower part of your ulnar bone, you could feel something popping up or popping out of it. That is the styloid process of the ulnar bone you are feeling. So let's finish up the section on the bones of the upper limb with the bones of the hand. The bones of the hand are numerous. We have a total of 27 bones of the hand, and these bones are grouped from proximal to distal into three major categories. So we have the carpal bones, then the metacarpals, and then the phalanges. Phalanges are usually bones of the digits. The metacarpals are usually bones found The metacarpals and the carpals are usually bones found within the carpal region of the carpal. So we'll talk about these bones each. Starting with the carpal bones, we have 8 major carpal bones. Right, 4 are found proximally, 4 are arranged distally, and these bones tend to form the major structure of the palm. So the palm bones are called the carpal bones. And this is a picture showing us the 8 carpal bones of the palm, and they're all labeled there from 1 to 8. We'll talk about each of them one by one. And remember that we have 4 proximal and 4 distal. So the 4 proximal are the ones that are very close to the radius and ulna. All right, so these are the 4 proximal bone here. And then we have the 4 distal bone, which are the bones that are close to the fingers or the digits. Starting with the 4 proximal bones, the 4 proximal bones include the scaphoid bone, the lunate bone, the triquetral bone, and the pisiform bone. And just a few things to note about each of them. So, in the way in which I've written these bones down is how they tend to start from lateral to medial. So, scaphoid is the most lateral bone. The scaphoid is usually involved in the formation of the wrist joint. It tends to articulate with the radius to form the wrist joint. So please do remember that, and it is the most commonly fractured carpal bone that we see. The reason is because of its blood supply. The lunate is the second proximal carpal bone, is the one in the middle. The reason why we call it lunate is because of it has a shape that looks like the half of a moon, right? And lunate therefore is medial to the scaphoid bone, and it's also involved in the formation of the wrist joint. It tends to articulate the radius to form the wrist joint, and the lunate tends to undergo fractures and dislocation when which can cause what we call an acute carpal tunnel syndrome, which we will talk about in the future when we get to the topic of species of the upper limb. The last or the third proximal carpal bone there is the triquetral bone. Triquetral bone is a bone that is the most medial of the proximal carpal bones. It also articulates with the radius, therefore is the third bone that gives rise to the wrist joint. And this bone tends to carry on it the fourth bone, which is the pisiform. So the pisiform is the fourth carpal bone. The pisiform directly sits on the triquetral bone, and the pisiform is referred to as a sesamoid bone. It's one of the smallest bone of the body. It's not the smallest, but it's one of the smallest bone of the body. Um, it is a bone that is involved in the attachment of the muscle that tends to attach to the pisiform bone is the flexor carpi ulnaris muscle, and is also serving as a site of attachment to the adductor digiti minimi, and it even forms part of the boundaries of the carpal tunnel and the Gonions canal. So this is a picture of all the proximal bones I just mentioned, starting with the scaphoid from the lateral to the medial. So the most lateral bone is the scaphoid, shown here in brown, followed by the lunate, which is the most middle of the 4 proximal bones. Then we have the triquetrum bone there, which is the most medial, and then above the triquetrum we have the pisiform, which is the smallest of the carpal bones, sitting directly on top of the triquetrum. Now the distal carpal bones are also 4 in number. Remember, we have 4 proximal and 4 distal carpal bones. Uh, each of these bones are named uniquely. So we have the trapezium, trapezoid, capitate, and the hamate. And this arrangement is done from lateral to medial. So trapezium is the most lateral bone of the distal carpal. And what you need to remember about the trapezium is that it tends to articulate with the metacarpal bones just like the rest would do, and also articulate with the scaphoid bone. It articulates with the first metacarpal bone, which is the metacarpal bone of the thumb. Then we have the trapezoid. Trapezoid is the second bone, medial to trapezium. Trapezoid, what is important to note about the trapezium is that it tends to serve as a site of attachment to the adductor pollicis muscle. Then we have the capitate. Capitate is the next bone. This is the third distal carpal bone. It's the largest of all the carpal bones. So remember that the smallest carpal bone we have is the pisiform. The largest is the capitate bone. Capitate also serves as a point of attachment to the oblique head of the adductor pollicis muscle. And then finally, we have the hamate bone. The hamate bone is the most medial bone among the distal carpal bones. The hamate tends to have a small landmark that we need to remember. And that landmark is called the hook of hamate. What is important to know about the landmark is that it serves as the point of attachment for muscles, particularly the flexor carpi ulnaris attaches to the hook of hamate. It also serves as a boundary or border for 2 major canals. The carpal tunnel and the Gonions canal are bounded like by the hook of hamate. Remember that they are also bounded by the pisiform bone. So the pisiform bone bounds them proximally, the hook of hamate bounds them distally. Right, to finish up on the discussion of the carpal bones, just want to quickly use this mnemonic for you guys to be able to remember the bones that form the carpal bones. We have 8 carpal bones, 4 proximal, 4 distal. These bones are the scaphoid, the lunate, the trochanterium, the pisiform, the trapezium, the trapezoid, capitate, and the hamate bone. One unique way to remember them is using this acronym that says this mnemonic that says she looks too pretty, try to catch her. So that's one particular acronym that stood with me for a long time when learning this topic. So the S there, she stands for scaphoid, looks there, L stands for lunate, 2 C double O stands for trochanterium, pretty then stands for pisiform, try there, the T, second T there stands for trapezium, 2, the second 2 there stands for trapezoid, then catch there is capitate, and her there is hamate. So she looks too pretty, try to catch her. That's one way you can remember all the bones of the carpals. Moving to the metacarpal bones, we have 5 metacarpal bones that form the distal part of the carpals of the palm. And these bones, each of them tend to have a base, a shaft, and a head. They are long bones. They are very small, short, long bones. So they would equally have proximal ends, distal ends, and the shaft. The proximal end of the metacarpals is what we call the base. So that's the part that's articulating with the carpal bones. The distal head is what we call the head. That's the part that articulates with the phalanges or the bones of the digits. And then the shaft is what connects these bones together. This is a picture of our metacarpals, and you can see there's a proximal part of it um, that forms the base. It's articulating with the carpals. There's the distal part of it that forms the head. It's articulates with the phalanges here, and then in between them there's the body or the shaft that tends to join the head and the base together. Then we have the phalanges. Phalanges are the bones of the fingers. They're small bones of the fingers. We have each of the fingers containing a total of 3 phalanges, with the exception of the thumb. The thumb only has 2 phalanges. So every other finger we have, whether it's the middle finger, the pointer, the index finger, or the little finger, they all have 3 phalanges. These phalanges include the proximal, a middle, and a distal phalange. The thumb only has 2 phalanges, the proximal and the distal phalange. And this is a picture of the phalanges. You could see that the first phalange, which is the phalange of the thumb, has just 2 phalanges there, distal phalanx and proximal phalanx, so just 2. Whereas the rest of the fingers have 3 phalanges each. So you can see, for example, this is the pointer. The pointer would have a distal phalanx, a middle phalanx, and a proximal phalanx. So if you calculate the amount of phalanges we have in total, we should be having a total of about 14 phalanges in the hand. So let's talk about the clinical significance of the bones of the upper limb. Right, the most important clinical significance of any bone in the upper limb is what we call fracture. Fracture is when we have a breakage or discontinuity of the architecture of a bone, either due to trauma, force, stress, or otherwise. So each of the bones that we've talked about, the clavicle, the scapula, the humerus, the radius ulnar, and then the carpal bones can be fractured. They can undergo fractures. Some bones tend to fracture more than others, and these are the ones we'll talk about in the clinical significance. The very first bone that we talked about, the clavicle, uh, gets easily fractured, usually in children. So fractures of the clavicle tend to be found more commonly in children. And this type of fracture that we see for the clavicle tends to be what we call a green stick fracture. Please do remember that. The reason why we call it a green stick fracture is because when it occurs in children, the pieces of the fractured bone don't get separated completely. So they are usually still united. Sometimes we usually see that the clavicular fracture tends to be more of a bend than a fracture because the bones just bend and then eventually they would get back to normal. And that's because the bones of children are very, very malleable. They're not so solid yet, so they are easily bendable. So instead of them breaking fully, they just bend as a result. So we call clavicular fractures green stick fractures because of that. Very important to note, the commonest site of clavicular fractures usually is found at the junction between the medial two-third and the lateral one-third. Sometimes you might see them say it's found at the junction between the middle third and the lateral third. See the same thing. So either the middle third or lateral third, or medial two-third and lateral one-third. That means the same. That's the commonest site of fracture of the clavicle, and that's because that's the weakest point of the clavicle. Then we're going on to the humeral fractures. So scapular fractures are not really so common. That's why we're not talking about them here. But for humeral fractures are very, very common. And there are four major places in the humerus that we can have a fracture. The first is the surgical neck. Surgical neck, remember I said, is the weakest point of the humerus. It's found at the proximal end of the humerus. The surgical neck fracture usually tends to affect a nerve. That nerve is the axillary nerve. So once the surgical neck fracture, that can affect the axillary nerve. And that's represented by this letter A. Then the second site where we can have a fracture is at the shaft. The middle of the shaft will get fractured, and this is what we call a mid-shaft fracture of the humerus. A mid-shaft fracture would affect one of the landmarks of the shaft, which is the radial groove. Remember that the radial nerve is found in the radial groove. And once there's a fracture of the mid-shaft, that can damage the radial nerve, and that can lead to symptoms of radial nerve palsy, what we call a wrist drop. And then finally, we have fractures at the distal part of the humerus, either at the medial supracondylar ridge or at the medial epicondyle. The medial supracondylar ridge is a part of the distal end that is above the medial epicondyle. If there's a fracture at the medial supracondylar ridge, the nerve that is most likely affected is the median nerve. If there's a fracture at the medial epicondyle, the nerve most likely affected is the ulnar nerve. Remember, the ulnar nerve is related to the medial epicondyle. It runs posterior to the medial epicondyle. And this is a picture of a clavicular fracture. Usually what happens when there's a clavicular fracture is that the medial part of the clavicle, or the medial to third and the medial end of the clavicle, is pulled upward. The reason why it's pulled upward is because there's a muscle that attaches to that medial end called the sternocleidomastoid muscle. That muscle will pull that medial fragment of the clavicle upward. Then the lateral fragment of the clavicle will be pulled downward, and that's done by the effect of gravity on the clavicle. Right, these are images of fractures of the humerus. As you can see, you can have a fracture at the surgical neck somewhere around here. You can have a fracture of the shaft, the middle of the shaft somewhere around here. You can have a fracture of the distal end. Remember that fracture at the surgical neck will lead to what we call damage to the axillary nerve. Fracture at the shaft could damage the radial nerve. Fracture at the distal end could damage either the median nerve or the ulnar nerve. So these nerves might not be so familiar to you guys, but we'll talk about them when we get to the brachial plexus, which is the next supplied to the upper limb. Other commonly fractured bones of the upper limb include the radius and the scaphoid bone. Radial fractures can occur in three major fashions. You can have a Colles fracture, a Smith fracture, and a Barton's fracture. I'll talk about what each of these fractures mean when we get to pictures. And you could have a fracture of the scaphoid. Remember that the scaphoid is the carpal bone that is most commonly fractured. And then we could also have a fracture of some of the other bones of the hand. And one of the commonest fractures is what we call a Bennett's fracture. So these are types of radial fractures that we can see. Usually, radial fractures tend to occur at the distal part of the radius. We can have a Colles fracture. In a Colles fracture, what tends to occur is that the fragments of the fractured radius tend to deviate or displaced, tends to be displaced dorsally. So there's a dorsal displacement of the fractured portion. So what do I mean by dorsal displacement? Once you have the fragmented portion, usually the lower part that is fragmented, being pulled upward, as you can see, is pointing upward. Right, so it's pointing posteriorly. That's what we call a dorsal displacement. That's what we see in Colles fracture. And we have what we call a Smith fracture. In Smith fracture, what we see is that the fragmented part of the radius tend to have a volar displacement, or an anterior displacement. Once the displaced or fragmented part of the radius is displaced inferiorly or volarly, then you could say that that's what we call a Smith fracture. And we have what we call a Barton's fracture. Barton's fracture is when we have multiple parts of the distal end being fragmented. There are multiple parts, or a fragment or fracture at the metaphysis of the radius. So this is what we see as we have just the metaphysis being fractured. It's not that we're seeing the separation between the shaft and the distal end. It's just the distal end that has been fractured in the Barton's fracture. Then we have the Bennett's fracture. Bennett's fracture is when there's a fracture of the base of the metacarpal, the first metacarpal, that's the metacarpal of the thumb. Once it's a fracture at the base, we call that the Bennett's fracture, and that's one of the fractures that we see for the metacarpals. Fractures that we see for the carpal bone is seen commonly at scaphoid. So the scaphoid is the most commonly fractured carpal bone, and that's because of the blood supply to the scaphoid. The scaphoid tends to be supplied by end arteries, and these arteries Some of them will supply some parts, some will not supply some parts. If there's a damage to one of the arteries, a part of it can become necrotic and as a result be fractured off of the entire scaphoid. And that concludes our model on bones of the upper limb.